It's my pleasure to introduce somebody you probably already know, Brian Talon. He attended Benedictine University and where he started his early research experience looking at antioxidant effects of amino acids. He then entered the PharmD program at UIC, where he worked with a number of faculty in a lot of different areas. And we were fortunate to attract Brian to the fellowship program in medication adherence, where he is currently in the second year of his program. And his current projects in the fellowship include a systematic review of the literature looking at the economic evaluations of clinical pharmacy services. And he's working on a program evaluation of a pediatrics program that we're working on with the pediatrics group here across the street at UIC. So with that,
thank you.
I'm going to turn it over to you, Brian.
Okay, so this is actually not my presentation, but a little bit under 2 years ago today was when I was standing here in this very spot for my interview for the fellowship, and it was on celiac disease generating value for pharmacological treatment. And I think that presentation went well, which is probably why I'm standing here. So hopefully this presentation goes just as well. So like Dan said, today I'll be presenting on a work sampling study of an innovative pediatric care coordination program called CHECK. So very different than what we're traditionally used to here in the research that's presented here in seminars. So not heavily econ-based or heavily epi-based. So sorry, guys. So my presentation outline, I'll just go through introduction, the framework that the CHECK program uses, specific background on the program, study goals, methods. There was a survey component to this, so I'll briefly go over the survey as well. We'll go over the methods that I use, results, strengths, limitations, and finally discussions. So care coordination is basically defined as sharing of patient information and proactive development of a care plan for a patient to achieve safe and effective care. So the AHRQ sums it up. The patient's needs and preferences are known ahead of time and communicated to the right people to provide safe, appropriate, and effective care. And some examples of care coordination programs, of course, communicating and sharing knowledge, but also helping with transitions of care. So for example, if a patient's admitted to the inpatient setting, communicating what happened in that episode with perhaps primary care providers that may not be aware that the patient has been admitted. Creating a proactive care plan. So shifting away from reactive care in which, a patient's not managed effectively in their chronic conditions and then they just continually present to acute care or the ED setting. So shifting away from that reactive-based care to more proactive care in which we prevent those exacerbations in disease and utilization of acute care services. Monitoring and follow-up of patient outcomes, supporting the patient's self-management goals, and most importantly, linking to community resources for the patient. So the basis of the CHECK program is on Wagner's chronic care model, which is based on these 6 pillars that I'll touch on the next slide. But the basic aim of this is to transform care of chronic illness into a proactive team-based care. And this could be done through, as I said, with the 6 pillars, one of them being community resources. So linking patients to resources in the community such as public screening events, self-management support. So developing the patient's knowledge and skills about their own disease state so that they can manage their conditions themselves. Delivery system design, which basically translates into involving a lot of people and providers in the patient's care, but having clear divisions of labor so that each person has a specific goal for the patient. And non-urgent tasks could be delegated to mid-level practitioners, social workers, and also mental health providers. And most importantly, clinical information systems. So actually having a registry or a database in which multiple providers can access to help inform themselves about the condition of the patient and events that have happened. So basically a health system with these 6 pillars, along with a patient that's active in their own care and a team that's proactively minded, will lead to improved outcomes. Practice models based on a CCM have demonstrated benefits in chronic conditions such as asthma, diabetes, and CHF patients, but mostly in the adult population. Medical home models, other care coordination models, team-based care models have also stemmed from this chronic care model. So CHECS stands for Coordination of Healthcare for Complex Kids, and it's currently a demonstration program funded by CMS's Innovation Grant. And the program mission is to, again, coordinate care for these children and also young adults by engaging with them, their families, and also the community that they're in to provide this very tailored and disease-specific management. The patient population in the CHEC program primarily focuses on underserved children and disease states of asthma, diabetes, sickle cell, and also prematurity. And the mission of the CHEC program is achieved through services such as health system navigation, care coordination, educating the patient and the family, coordinating care among various providers, so not only with providers here at UI Health, but affiliated sites in around the Chicagoland area. And also addressing mental health and social needs, which is somewhat unique to this program, and of course, community outreach. So the CHEC program consists of 3 fundamental and important employees. So they're community health workers, or CHWs, care coordinators, and mental health workers, MHWs. Community health workers make up the majority of the program, and they're a field-based staff that work for the CHEC program and actually live in the communities that they serve. They can identify mental health conditions, social needs that the patient may have. They help patients and families, of course, coordinate care and navigate the health system. They link patients and families to services that are in their community, and they also provide education for disease management and also goal setting for the patient. Care coordinators manage the CHW teams, and they assist in coordinating and facilitating patient services. And the MHWs primarily handle mental health needs of the patients. They perform direct services such as therapy sessions, counseling sessions, patient education, other preventative services, and also they provide consultative services to the mental health worker or to the CHWs and clinicians that work with the patient. So this is a summary of what the CHEC program delivers for the patients. And if we compare this to the chronic care model, we begin to see how the services of the CHEC program utilize this model and feed into it. So we have community members as part of the CHEC program that are adept in the cultural understandings of the patients. They perform patient and family education, community outreach events. Actually, they have a cool dental van. It's a little like mobile dental service that goes into the community. So that kind of fits into the left-hand side of the diagram. And then on the health system side, they provide care coordination, health system navigation. They actually have a contract with Uber that helps patients coordinate transportation to and from their clinics. They have a database to track patient needs and outcomes that providers can access. And they also utilize technologies such as a telehealth program in case the patient is not very accessible. So the aim of our study is to determine the time allocation of CC, CHWs, and MHW to their respective tasks over a 6-month period. And this data can help us determine operational costs, but most importantly, and what the true goal of this study was, to inform resource allocation within the program. This is a sub-aim of an overarching project that we have to perform a return on investment and also a cost-effectiveness analysis. So using this IPO model, input, process, and outcome, we need to know what the inputs are, how the program utilizes those inputs and what the outcomes are. So this aim, which I have underlined, which is kind of aim 2, is to measure labor cost. Aim 1 we've already completed a while ago, and that was to measure fixed and variable program costs. And the other aim on the other side is to measure outcomes, which is total cost of care and also quality indicators. So it's kind of a big project, and this is just one part of it. So the methods that we use, again, is work sampling. And here I just wanted to compare and contrast the method of work sampling and time motion. So in a work sampling method, an observer takes a snapshot of what MHW is doing. So it's just a snapshot in time of where they're at, what activity they're performing, and for who. This can be done through direct observation or self-reported logs. And the way we calculate the proportion of time is basically the frequency of the number of times that we observe that task divided by the total number of observations that we made. Advantages to this method is it's not very resource intensive because we're just observing someone for a very brief time period, maybe like a few seconds or so. And with that, we're able to sample a large amount of subjects. Disadvantages include that self-reported logs may be missing or inaccurate, not filled out properly. There's less detail in what the worker is actually doing because, again, we're just only taking snapshots of time. Hawthorne effect is possible, but I would say less so because it's a very brief observation period. And there could also be misclassification of tasks due to this just taking a snapshot. In contrast, in a time motion study, we have an observer actually follow around a community health worker and record the exact amount of time that it takes to perform a task for a patient. The advantages to this is that it's the most accurate measurement of time, but it's very resource intensive. So I don't really have the time to follow someone around in the field. But again, we try to manage. Disadvantage, again, very resource intensive and more prone to the Hawthorne effect since you are actually observing that worker. So we use a work sampling method over a 6-month period, beginning in May, so during finals week last semester, and we just actually concluded about a week ago. So random subjects were sampled or observed at random time points to determine the activity that they were performing within working hours, so kind of like a 9 to 5. We use a uniform distribution to randomly select a time point between 9 to 5 and also to select a subject to be texted. And this randomization of selecting a time point in the subject reduces potential sampling bias in our study. So just to give you a brief kind of visualization of how this works is I text someone at 9:15, and this is within a typical 8-hour day, and I observe them to be performing task 1. I observe them again at 10:30, and again, they're performing task 1. Okay, I missed task 2 because that was kind of in the middle of the day, and the next text didn't come until 1 p.m., and then at that time, they're performing a different task, task 3. I observe them again at 1:30, and they're still doing task 3. 1:50, same thing, and then I only text them 5 times a day, and so I missed task 4. So if I were to calculate out, the proportion of time dedicated to a particular task here, I would see that it's about 60% task 3 and 40% task 1. But then I didn't get task 2 and I didn't get task 4, which could be, an important activity. But over time, if I observe them, continually over a 6-month period and just keep sampling them, then the estimate of a work sampling study would approach that of a time motion study. So it's as if I actually followed them around every day for 8 hours over a 6-month period. And then I'm able to capture all the tasks that they perform, and then my measurement of that time becomes more accurate. So to be eligible for this study, you have to be a CC, CHW, and MHW of the program, of course. I trained them for about 15 to 20 minutes just to inform them of, I had to consent them to familiarize them with the study methods and how to properly respond to the text messages. The survey development was actually, it was the hardest part of this. Just because I asked the administrators first how to categorize all these tasks, and then when I actually piloted it on the workers, it was like, this is not what we do. So there were a lot of iterations of the survey to go through. So we use focus groups consisting of administrators, CCs, CHWs, and MHWs. And the whole point of the survey was to determine at the point of sampling, where were they? So were they in the office? Were they on the field, the patient's home? Who they were interacting with. So it could have been the actual enrollee, so the pediatric patient, or perhaps a family member, the activity that they were performing, and other tasks that they may have been doing. So for the CC survey, they just had one question, and it's basically at this moment, what were you doing? Which could be training, a CHW. It could be team management, so working with the CHWs to coordinate care. Hospital management, so CCs actually go to the hospital if someone's admitted, or they go to the ER if one of their patients presents to the ER, or consultations with other providers. And then, of course, so that they actually can answer the text message, we had to put filler categories or catch-all categories so that they could actually exit the survey. For CHWs and MHWs, same structure of the survey, except just different task categories, and theirs was much more complex. So first we would ask them where they were. So they could be in the field, which we define as either the hospital, the patient's home, or somewhere else in the community, or they could be here across the street in their offices, or they could be off. At that time, we would ask them who they were providing a service to. So it could be the check enrollee, so the actual pediatric patient, or it could be the parent or the parents or caregiver of the enrollee. Next, we would ask, so if they answered A, I'm with an enrollee, then we would ask, what condition does the patient have? Asthma, diabetes, sickle cell, prematurity, none of the above. And they were able to select multiple categories if the patient, for example, had asthma and diabetes. And then next, we would ask what risk category was the patient, and risk was defined as prior use of either the ED or a prior hospitalization. I'll go through that in the supplementary slides. And then lastly, we would ask what service they were providing for that patient, which could be health promotion, ASC, which is assessment, screening, and care planning. Maintenance activities. Maintenance is when they actually go to the patient's home and perform a check or a follow-up, or none of the above. If they answered that they were with the family member and not the enrollee, we would ask the same thing: what service are you providing to the parents or the caregiver? And if they weren't doing any of the following, so they were not with a patient and they were not with a family member, they have this other category. And of that, they could choose whether they were performing consultation, documenting in the database or the EMR, or they were on break. For the MHW survey, same exact structure, except that the task category is different. So as you see there in question 5, preventive service or assessments, appointment referrals to escalate a case, direct service such as therapy sessions, or actually a DVD task in which they pop in a DVD and they kind of like walk through different scenarios that the patient may have in terms of their disease condition. And then same exact structure for the remaining part of the survey. So we use Microsoft Excel to randomly pick a time point and a random employee, and then I would have to enter it manually into MyTap, which is the text messaging platform that we used. And subjects were asked to answer the questions at a convenient time to minimize workflow disruption. So when we were piloting this, they were answering it right away, and they may be in front of a patient, and we didn't want that because it kind of ruins the dynamic between the provider and the patient. So we would ask them to perform it at a later convenient time, perhaps when that interaction was over. And they would refer to the time point of sampling to answer that question. So in all our phones, we have time tags on when text messages come in. So we would ask them to refer to that time tag if they were going to answer it later. And the analysis wasn't too complex. We're just doing proportions, so it was done in SPSS. So for the results, we have very good response rates over a 6-month period. For CCs, 74%, although there were a small number, about six CCs. CHW, 65%, and MHW, 62%. And this is just for question 1. And if they answered question 1, they were very likely to answer all subsequent questions because over 90% of the subsequent questions were answered. So this is our patient flow diagram. So CCs, there's not a lot of them, just 5. And at study end of last week, we had 1 remaining. For CHWs, there were 20. I think there were probably 22. 2 of them I missed. But we had 8 subjects at study end. And then for the mental health team, a very small team, we only had 1 at the end. So on to our actual results. So for CCs, most of their time was spent on team management and hospital management, which is depicted by the gray and orange pies. For CHWs, most of their time was spent in the office. And for CHWs, a relatively equal amount of time between enrollee, family, and other tasks. And this pie chart on the right-hand side was if they were with the enrollee. The majority of the care was provided to asthma patients at 62% and diabetes at 14.3%. And then of those enrollees, most of the services were provided to the medium risk patients. So 58% of the time was for medium patients. And then of that same patient, what service were they providing? And it's overwhelmingly assessments and care plans at 54% and maintenance tasks at 27%. And again, maintenance is when they're actually at the patient's home. And then if they were not with the enrollee, but they were with perhaps a family member or caregiver of the enrollee, we see the same pattern. 60% of the time they're providing these assessments and care plans and also maintenance services for the caregiver. And for CHWs, 37% of their time was spent if they were not with the patient or the caregiver. And as we can see here, 54% of that piece was spent on none of the above. So there was something that we weren't capturing. And then also 40% on documentation and research. So documentation is being in the EMR, and research is if the CHW perhaps needed to look up something about the patient, about their condition. So that's what research was. For the MHWs, not primarily field-based, so again, 80% of their time is spent in the office. And 16% of the time is spent with the enrollee. And if they were with the enrollee, again, we see the same pattern that we saw with the CHWs, mostly asthma patients at 54%, and then the next highest category is diabetes at about 14%. Continuing with that same patient, mostly medium to low patients. So medium is about 24%, low risk patients about 41%. And this, in terms of the services being provided for that patient, mostly prevention and assessments for that patient at 70%. And if they were with a parent or a caregiver, again, mostly prevention is assessments at 64%, and organizing appointments and referrals at about 22%. And a big chunk of time was being allocated to this other category. And when we look at this other category, we see that staff meetings took up about 28% of the time, or 27%, and documentation research at 32%. So onto the discussion. So the majority of CC time was spent on team management and hospital management, and this is exactly what we wanted to see because CCs routinely follow up with CHWs to coordinate care with their patients, and also follow up with patients that have been admitted to the ER and that have been admitted to the inpatient setting, because it's, entering this information into their documentation software, which is accessible to other providers. That information is what's vital for this care coordination service, that everyone knows what's going on with this patient. So that was good to see. And we are also focusing very heavily on the patient and the family, because about 63% of CHW time is for the patient and family, and 45% of the MHW time. The majority of the population that the CHECK program serves is asthma, which is about 75%, so about 3/4 of the population. And about 50% of the time is allocated to asthma, so that does make sense. But we also have to understand that there's a lot of disease education and just education and counseling in general that goes into an asthma patient. Educating on the disease state, developing an asthma action plan, knowing how to execute an asthma action plan, assessing for triggers in the home. So the CHW is actually kind of go around the home and assess for possible triggers in the home setting. And of course, administration technique for different types of inhalers. So perhaps, the time allocated to asthma may be reduced a little bit, but without impacting quality. CHWs and MHWs mostly interact with their medium risk enrollees. Again, this makes sense because most of our population is medium risk, but also due to that the low risk patients don't really need a lot of attention, so they're not followed up frequently. But then the high risk patients are actually referred out, or their care is escalated. And this is especially true for the mental health team. So if a mental health care worker deems that a patient is very high risk, they're actually referred out into a community health clinic where they can receive closer follow-up and weekly therapy sessions. Also, the majority of time of CHWs and MHWs are spent on patient care activities. So 70% for each are devoted to developing assessments and care plans, coordinating care, visiting patients in the home, and also for the mental health team, performing these mental health assessments and educating the parents and the child as well. And the reason why we saw a lot of the MHW time in the office is because they're almost exclusively using telehealth. Because there's such a small team, they can't take all 4 people out into the field and visit patient homes, especially when a mental health assessment can take up a significant amount of time. So overall, the CHECK program is operating as expected according to the model that we're based on, and that's coordinating care, promoting self-management, and providing proactive care. If it's not documented, then it didn't happen. I learned this the hard way when making those SOAP notes here, and it was like 20 pages. Everything had to be documented. So most of the remaining time that is not spent with the enrollee or with the caregiver spent documenting. 40% of CHW time and 32% of MHW time. So if we go back to the chronic care model, we wanted these like big patient databases that providers can access to inform themselves about the status of the patient and the type of care that they're getting. So here, these employees, the CHWs and MHWs, have to document in Cerner so that clinicians in the hospital know what's going on. Then they have their own CHECK database, which is called Consensus. And then they have another software program called Purple Binder, which is kind of like a social work database that has numerous community resources that you can refer a patient to. So there's a lot of softwares that they have to go to and document and get resources from. So documentation is absolutely necessary, but burden could be alleviated, and this time saved could be dedicated more to providing care for patients and doing other patient care activities. And also, CHWs reported a very high amount of other tasks, so there was something important that we didn't capture. So we're planning on performing a follow-up focus group to determine what exactly that is. So what and who cares? I was hoping Dr. Crawford was here. So the results of the study can help us inform improvements to increase efficiency of the program. So definitely, maybe that asthma time, the time dedicated to asthma patients, can be reduced without sacrificing quality. Perhaps the biggest thing is streamlining the documentation process. And most importantly, we saw that the program is operating, as we expected. Most of the time is dedicated to seeing patients and performing these care activities. So we definitely want to maintain that sort of activity for the parents, the family, and for patient care activities. So strengths of the study. So the use of text messages eliminates the influence that observation can have on the subject's behavior, so Hawthorne effect, I guess. Text messages reduce the burden of these paper-based or self-report papers that I would have to go through, and maybe they're missing. And text messages are very convenient to answer. We did have a long 6-month observation period, which improves accuracy of the estimates. Most of the literature I've seen have been very short-term observation periods. And we were basically able to sample all the CHWs, TCs, and MHWs. Study limitations. So, of course, this is a work sampling study, and even though that we had a very long observation period, the proportion of time that's allocated to a task, of course, won't be as accurate as that of an actual time motion study. And so we're extrapolating these proportions to determine an exact length of time, but it's really not the exact length of time. There could be recall bias, so subjects could have waited until towards the end of the day to answer a text message. And there may also have been bias in the results in terms of maybe some of the mental health workers had a lot of meetings in the morning, so they weren't able to answer those messages in the morning, so we can't see what they're doing in the morning. There could be overlapping tasks, which was very difficult in creating the survey, because some of these tasks overlap. We really had to put them into strict categories, but it may not necessarily be strict categories in the field. Limited depth of detail beyond what we observed, again, because it's a work sampling method. Subjects may not have known of secondary diagnoses, so we received a small proportion of CHWs indicating multiple diseases. We anticipate a little bit more, but that information may not be readily available at the time of the patient interaction. And we still had a relatively small sample size, and you could see that with the confidence intervals, especially for the MHWs, because we only had about 5 the whole entire period, and the care coordination team is only about 6. And we did have some dropouts in the middle, so that, of course, affects our accuracy. I'm way early, okay. So in terms of the branch logic for the text messages, so this was for the CCs. So again, they only got 1 question. So they actually didn't mind the study. But for the MHWs and CHWs, very complex. You got to kind of sit there for a few seconds to answer these text messages. So this is the overall tree structure. For the task categories for the CCs, so mostly team management and hospital management. So team management, again, coordinating with the CHWs, hospital management, hospital rounds, ER management. For the CHWs, so ASC, CHWs, so assessment, screening, and care planning. So these tier 1, tier 2 assessments, and that's dependent on, I guess, the level of severity of the patient. Care planning, phone calls, ED assessments. And again, maintenance is where they actually perform visits, or they're texting patients, performing care coordination activities. And for mental health, preventative services, so this is again those tier 1, tier 2 assessments, follow-up assessments, and linking patients to mental health clinics within their community. And for the risk level, so this is how they defined risk level. So low was no ED visits within the last 12 months, no hospitalizations within the last 12 months. Medium, 1 to 3 ED visits and one hospitalization. For high, it was greater than 3 ED visits or greater than 1 hospitalization. And that's all I had. Actually, I thought I was going to go over.